Hey folks, everywhere you are in Western Washington and probably anywhere else in the United States, once was the land of Native Americans who were here long before us white folks. Even though I have ancestors who were here in the 1630s, that still isn't early enough. And they just sort of came over and said, move over, we're here. So anyway, we owe a debt to the Native Americans of this area who took good care of the land and its riches.
Great. Okay, let's get started here. So as you guys all know, an effort to privatize traditional Medicare is now underway through Medicare Advantage plans and the previously under the radar direct contracting entity or DCE plans that are controlled by for-profit health care insurance companies, venture capitalist outfits, and other Wall Street interests. So the intention is to move all Medicare beneficiaries into privatized programs by the year 2030. In fact, there are now 5 or 6 DCEs operating in Washington state. So these were started under Trump, but are continuing under Biden. They allow the DCEs to pocket up to 40% of their Medicare trust payments as profit and overhead versus 15% for Medicare Advantage and 2% for traditional Medicare. As I mentioned, until recently, DCEs were intentionally under the radar. Traditional Medicare patients are now being assigned to a DCE without their knowledge or giving their permission. But the battle is heating up as awareness is growing, and that's why we're having this program tonight. First, we'll set the background and then see a great slideshow and talk about what we can do to help stop DCEs. So first, to set the background a little bit. This one I borrowed from last night's PNHP New York Metro chapter slideshow. So just a couple of slides here. There are many problems with traditional public Medicare, and we know about those. Basically, they cost people $6,000 a year. They don't cover essential things like dental, hearing, and vision care. That has costly deductibles and copays. And so an effort was underway. I don't know when Medicare Advantage started, was at least 10 years ago.
Oh, it was in the late 90s.
Yeah. So the pressure to provide an alternative to Medicare was a private plan that Congress created, the Medicare Advantage program. And you can see here that Medicare funds go into the insurer who doles them out here. But they are capitated payments. So the bottom line is costs the government more. Medicare Advantage costs the government more than public traditional Medicare. Gives less care to those who need it most. So if you have a Medicare Advantage plan, you think you got a great plan because it covers dental and hearing and so on. But then if you get sick, then you find the out of network problems, and you have to get somebody to approve the service or healthcare that your primary care or provider recommends. It has to go through the Medicare Advantage plans, which very often denies it. If the physician or provider objects to that, they can go back to the plan and say, take another look at it. And most of the time, it goes through then, but people who get denied that care, often, only a small percentage of them, take it further and talk to their physician about getting it accomplished. So since insurers receive a per person capitation payments, they don't, that doesn't depend on what they spend. They provide less care, and and the less care they provide, the more money they make. So now Medicare Advantage plans, this new one, which was started, I think, a couple of years ago as a pilot program, this direct contracting things that we're going to be talking about tonight. So basically, CMS is committed to sharing the goal of moving away from fee-for-service to the goal of moving 100% of traditional Medicare beneficiaries into accountable care relationships, such as DCEs. Okay. So now we'll look at this fabulous slideshow that's narrated the last 20 minutes. And you can unmute yourself and, yell out, I want to stop here and talk about this as the slideshow progresses. We don't have to wait until the end of it, because after the slideshow, we're going to be talking about what's been going on through PNHP and other progressive healthcare organizations to stop the DCEs. So let me ask, how many people have already seen this slideshow? Because I've been putting out the link to it for a couple of weeks now. So I hope most of you haven't. So anyway, it's a great slideshow. So let me start it here. And remember, you can, perfectly happy to stop it and talk about it. This is put together by Claire Falk for the PNHP National Office in Chicago, who's the communications specialist.
What we really need to do is ramp up the campaign.
Are you hearing
very
this?
Quickly. And an important part of that is getting out in the communities and talking to seniors and talking.
Are you able to hear this?
Yes.
Okay, good.
I hear it clear.
Okay.
Community groups in our areas, and a lot of that is the work that the activists and chapters are going to be doing. So what I have for you tonight is talking about direct contracting 101. And this is really just an overview, give you some ideas for when you go out and speak, specifically to senior groups. And before we get into the content and the messaging, I just wanted to step back and say, why are we talking about seniors right now? When before now, we've been very much focused on messaging for members of Congress, messaging for journalists. We think it's worked fairly well. Why are we going directly to seniors now? I mean, obviously, seniors are the ones who are most affected by this program. They're natural allies. That's fairly obvious. But we also need to remember that direct contracting will radically transform Medicare. We need to be clear about this. This isn't just something that's affecting seniors today. This is something that's going to change Medicare forever. So not just seniors, but anyone who's going to be a senior at some point in their life should be concerned. But the reason we really want to reach out the seniors in our community is because we're not going to win this fight without having an army of seniors on our side, because seniors vote, they call their members of Congress. There's nothing a member of Congress fears more than an army of pissed off seniors banging down their door. So that's what we're going to do. So when you're speaking to groups in your community, you may have an hour, you may have 30 minutes, you may have 2 minutes, but no matter how much time you have, there's 3 key ingredients I want you to have in your presentation. I want you to educate, advocate, and activate. And I'll briefly explain what I mean by those 3 things. So educate is probably the most important, because this is something that almost no one has heard of, especially until now. So it's going to take a lot of time. And if you have the time, try to spend it on the education part. Explain in very simple and concise terms what direct contracting is. That's probably your biggest challenge right now. And then you can move on to advocating, which is a little bit more fun. Explain why this program is bad news for both seniors and Medicare, and try to unpack some of that. Well, like we were saying, some of this jargon around value-based care and saving money and coordinating care. Let's kind of cut through that and talk about what's really going on. And then finally, you want to activate. I think especially now, our potential advocates may feel like they can't really make a difference. So it's your job to challenge them, get them excited, and give them the tools to get involved, give them something to do, give them concrete action steps where they can get involved. And we'll have more of that at the end. So that's kind of the, the overview of how we should generally talk. Now, this is more getting into the messaging when we're talking to senior groups. So just what's our basic understanding of what direct contracting is? So it's a program that was launched late in the Trump administration that would change the way that Medicare pays for seniors' care in traditional Medicare. So instead of paying doctors and hospitals directly, Medicare gives these third-party entities called direct contracting entities, or DCEs, a payment to manage seniors' care. It manages in quotation marks, and allowing them to keep as overhead and profit what they don't spend on medical services. So here's a simple way to look at it. Traditional Medicare, it's very straightforward. Medicare pays your provider directly for the care that they provide. Under direct contracting, Medicare now pays a middleman called the direct contracting entity to, quote, manage your care. They're the third party between Medicare and your provider, and to a certain extent between the patient and provider, but we'll get more into that. One thing that's very unusual about this is that it's a big change, but it's completely under the radar. And this would be a good time, if you are giving a presentation, ask your audience, who here has heard of it? Now that I've explained it a little bit, who here has actually heard of direct contracting? Everyone's going to raise their hand and say they've never heard of it before, which begs the question, how is this happening without any of us knowing about it? So if you have time, it's a good opportunity to talk about the structure of, who controls these agencies and how this came to be without congressional oversight. So let's dig a little bit into who's in charge. So this is the organizational chart for Health and Human Services, which is the agency that's responsible for most of our nation's healthcare system, to the extent that we have a healthcare system. And the head of that agency is Secretary Javier Becerra, who is appointed by President Biden. So he is the person who's really ultimately responsible for making the decisions about what happens, within this flow chart. And that's why our petitions are geared towards him. Now, who's actually responsible for Medicare itself? It's the Center for Medicare and Medicaid Services, which is CMS. For some reason, they dropped the second M in there. They're the ones that manage Medicare. But if you look at how CMS is organized, this is the flow chart for CMS. If you look really, squint your eyes and look really closely, you see there's this tiny little agency within CMS called Center for Medicare and Medicaid Innovation. And they are the agency that came up with direct contracting, and they've been empowered to come up with these pilot programs and expand them to all of Medicare or Medicaid without congressional approval. And this is really key, and it's worth repeating in your presentation. They do not need congressional approval to do these pilot programs or expand them to all of Medicare. So, and I'm glad that I think it was Andy who brought this up, our friend Adam Baylor, I think that's who you're thinking of. So when direct contracting was first developed in 2019 during the Trump administration, Adam Baylor was the head of CMMI, the Center for Innovation, and he was the former roommate of President Trump's son-in-law, Jared Kushner. And so he was in charge of CMMI. They started direct contracting. Now, the fun thing is that before he ran CMMI, Baylor ran a startup called Landmark Health. Now, Landmark Health became one of the first DCEs to contract with Medicare for the direct contracting program. So clearly as soon as this program started out, there were already conflicts. And it was, already kind of a suspicious program. So now that we've sort of peeked under the hood at the agencies that are responsible for this program and for its very controversial start, let's look more closely at the DCEs themselves and the people behind them. So first, we should say that it's still a very young program. It only started in April of last year, but it's already DCEs are already operating in 38 states and DC and Puerto Rico. So they're nearly everywhere right now, even though this is considered a pilot program. Now, virtually any type of company can be a DCE, and they don't have to have healthcare experience at all. They basically just have to have the startup money to get going. And again, applicants are approved without input from Congress, as is the case with all these decisions coming out of CMMI. And I'm going to pick on one DCE. This one is called Illumed, and for some reason they don't like to capitalize the I in their name. Okay. So if you look at, this is from their website, this is their leadership team, and you'll notice that only one member of their leadership team has any experience as a healthcare provider. The woman I circled in red is a nurse. And not that we would be okay with this model if there were more providers in the leadership, but just to show you what this is really about. Now, the news page on the Illumed website actually tells us even more about how their business works. There's the two top articles on their news page. The first is they just recruited a chief medical officer. So this is a year into running this program, and they just now have a chief medical officer. And interestingly, they recruited him from Humana, which is a commercial insurance giant that's very involved in Medicare Advantage, and that's where he actually previously worked. So that gives you a clue of what kind of model they're looking for. But I think more importantly is the second article about raising $16.5 million from Wall Street investors. That's a lot of money for a company that's relatively small within this space. So this is the question then, why are Wall Street investors so interested in a company that claims it's going to save money for Medicare and improve care? So again, back to this chart of how the money is flowing. We started with Medicare, now Medicare's paying direct contractors who are paying providers. But what we don't see are the Wall Street investors who are paying these DCEs. So this is who the DCEs are ultimately responsible to. And they've got to make the case that they can somehow make lots of money and make their investors happy. Now, these investors are not dumb. They know that the money is going to be coming back into their pockets. So what's the plan? How are they planning to keep these investors happy? So what's the question? How do direct contracting entities actually make money? Well, it comes down to two things. One, they need to maximize the revenue that they get from Medicare. That's the money coming in. And second, they need to minimize the revenue spent on patient care. So minimize the money that's going back out. That's how they're going to make that 16 million back. So first, let's look at the money that's coming in. And this is very important. And I'm going to get a little wonky, but I think if you have time to explain this, it's worth explaining because this is really key to their business model. So the first way that they make the money come in, they engage in a thing called upcoding. And if you know about Medicare Advantage, you probably know what that means. But you basically make seniors look sicker than they are because DCEs get a monthly payment from Medicare that's based on the diagnostic codes, how sick the patients look, not how much they're paying for healthcare, but how sick they look. So let's break down what upcoding looks like. And I blatantly stole this from one of Ed Weisbart's presentations. But a typical coding of a 76-year-old female, you see obesity, diabetes, asthma, pretty typical diagnoses. Each one of these comes with what's called a risk score. If you add up the scores and then do some, there's a formula. Medicare pays each DCE, would pay the DCE $9,000 a year for this level of risk scores. Now, if you take that same patient and do some upcoding, you see that they took obesity and made it morbid obesity. They took asthma and made it COPD. The ulcer is now stage 3 and so on. You see in red where the upcoding happens. So usually it's the same diagnosis, just more extreme or a different diagnosis. So the risk score is 3.63. And now the annual payment from Medicare to the DCE is $32,000. So more than 3 times the amount if they did not do upcoding. And it's important to emphasize that this has nothing to do with the healthcare that they are providing to the patient. It's just what's in their records. So that's how the money comes in. And as you can see, there's a huge opportunity to just keep bumping those scores year by year. So we've established that DCEs, they're essentially using seniors to get higher payments from Medicare, regardless of the care that they're providing. But on the other end, how do they keep the money from flowing back out? How do they keep from having to pay for the actual care that they're supposed to be giving? And as we mentioned, because they're allowed to keep as profit and overhead what they don't spend on medical services, they now have this very dangerous incentive to ration and restrict care. And the program is young enough that we don't have the data on what that looks like yet, but we know that that is an incentive that is, I mean, it's guaranteed that this is going to happen because that's the incentive. And importantly, these financial incentives do not exist in traditional Medicare. Medicare is fee for service. You pay for the health services, and that's it. So this is a radical change to traditional Medicare. So now in the next part of the presentation, or of your presentation, again, this is sort of a template. We're going to talk about advocating. So we're going to talk a little bit, we went through the nuts and bolts of how this works. Let's talk about the kind of bigger picture reasons of why we need to stop the program. And the two reasons, the first is direct contracting threatens Medicare's solvency. The second reason is that it threatens seniors' health care and healthcare choices. So first, what do we mean by solvency? And that's basically, it's a fancy way of saying that this program could bankrupt Medicare. And that's what we're going to be talking about in our Senate hearing next week. So we all know traditional Medicare spends 98% of its budget on patient care, only 2% overhead. In contrast, direct contracting, the entities only spend an estimated 60% of what Medicare pays them. So remember that $32,000 that Medicare is paying, they only have to spend 60% of that on patient care and can keep the rest as overhead and profit. And just to give some context, like a visual context, you see Medicare 98%. That's very efficient, great ratio. And even Medicare Advantage, they're still taking 15% in their pockets, but they're required to spend 85% on patient care. Now, DCEs, they don't even have that 85% requirement that Medicare Advantage has. And this is an article from Health Affairs in the fall that calculated that basically they only have to spend about 60% on patient care, and they can keep the rest. So this should be shocking to anyone that this amount of waste of our taxpayer dollars are going straight into their pocket and not into seniors care. So the other reason that we need to stop direct contracting is that, we've talked about the dangerous incentives for DCEs to restrict and ration care. We know that, but on a deeper level, it undermines seniors' choices. So under this program, up to 30 million seniors who actively chose traditional Medicare because they value having a free choice of provider may be automatically aligned with the DCE without their full knowledge and consent. And aligned is the CMS's way of saying assigned or enrolled, but we'll use their language, aligned. So how does that happen? So CMS will search 2 years of each senior's claims history to see if the senior has gotten care from a DCE aligned primary care provider. And then they will automatically enroll the senior with that DCE. And the senior will get a letter, maybe, that looks something like this. This is a letter that someone sent us, that it's informing them that they're now part of this DCE. And of course it says no action needed. And if you're like me and you get a letter that says no action needed, it's probably going to go straight into the recycling. You're not going to pay that much attention to it. And it's a lot of gobbledygook, but most seniors aren't going to understand what this means. So if you're a senior and you find that you get this letter and you're now, because of your primary care provider, aligned with the DCE and you don't want to be, the only way to opt out of the DCE is to change primary care physicians. And we should make this definitely a part of every presentation. You have to change your doctor if you don't want to be in the DCE. And that's a big ask for anyone. But if you imagine being in a rural area or underserved area, it could be nearly impossible. So logistically, that's a challenge, but it's also undermining traditional Medicare's promise of free choice of provider. This is why seniors, majority of seniors choose traditional Medicare, because they want that choice. And you're undermining that choice and undermining that promise. And the other reason is, even if you're not a senior right now, you're not on traditional Medicare, as I think it was Ollie had mentioned, CMMI has said in the last few months that their intention is to move all fee-for-service, that means traditional Medicare beneficiaries, into one of these, value-based, however you want to say it, into one of these plans by 2030, or maybe even sooner. So this is a radical change to Medicare, and it's happening very, very quickly. And it's going to completely change Medicare. The Medicare as we know it just simply won't exist if we let this continue. So we need to get in this fight. And finally, in the advocate category is where's Congress in all of this? And you can see our folks standing in front of Congress. Why isn't Congress trying to stop this? Why aren't they involved? Well, until recently, most members of Congress had never even heard of direct contracting. And that's for good reason, because this was a program that was designed to fly under the radar. So the good news is that we've been working really hard, including everyone in this picture and everyone on this call has been working really hard to talk to our members of Congress, to talk to reporters, write letters. And just a couple of weeks ago, 54 members of Congress wrote a letter to HHS demanding an end to the program. So the awareness is definitely rising. Bad news, as Susan mentioned, is now the DCE owners and investors are fighting back because they know that we're coming after them. We're no longer under the radar, we're above the radar, and it's making them crazy. So we're entering the next phase of this fight, and we need everybody to get involved. So this is where we get to the activate. So now we've got people are riled up. They feel like there's a chance to actually stop this thing. We think we can win. What can we ask people to do? This is something that's definitely should be part of every presentation. So if you're just talking to a group of individuals, the best way to get involved is to sign and share our petition. And note that if you do sign up for the petition, you'll join the mailing list. So they'll stay up to date on everything that's going on. So as the campaign evolves, they will still be in the loop on what's going on. And they could also write a letter to their local news outlet. And we've got tips for that on our website. And as Susan mentioned, that seems to really be getting under the skin of our opponents in the DCE industry. And then if you're talking to an organization, the one thing we want them to do right now is sign on to, we have a sign-on letter for organizations against direct contracting. We want to get as many local and national groups to sign on. They don't have to be Medicare for All supporters. We want everyone who's concerned about this to sign on. And we can put the link in the chat for that letter. And also they could share the petition with their members and other community groups. The petition is probably the single easiest and best way to spread the word about this. And that's it for me. I will, I can put a link in the chat of a template of this slideshow. I mean, without the beginning part of me talking about what you should have, the activate, the educate, activate, with just the content. I could put that in there so you can download that and play around with it and decide what you want to use. And as I mentioned, we're going to have a training on the 16th, a standalone speakers training on the 16th, where we'll talk in more detail about messaging and also have a chance to really be more interactive and maybe practice what are the common questions that we get from audience members and how we can respond to that, so that everyone will be equipped to speak to community groups, maybe even to reporters, to anyone or members of Congress, to anyone that they want to talk to. But really, our main goal right now is to expand this to seniors.
Okay, so now you're all up to speed. So anybody want to discuss something they saw there? I should say that she mentioned that letter that Pramila Jayapal sent to Basara, signed on by 56 of her colleagues, to ask Becerra to stop DCEs immediately. So that was the letter she talked about. And we, about the sign-on letter to Becerra for organizations that recently have been passing around here in Washington the last few days through our PNHP Washington email list. And, so far there's 6 or 8 organizations in Washington state that have agreed to sign on, and I could name those somewhere. But anyway, WACAN, Washington Community Action Network, was actually the first one before we even knew about this for just. So North Seattle Progressives, Northwest Health Law Advocates, PNHP. I expect that PSARA, I think I said they're going to sign it, but I got the list today of the updated signers, and it hasn't reached Chicago yet. There's 3 or 4 other Backbone Campaign, and I think Healthcare for All Washington is going to sign on because it's definitely something that there shouldn't be any opposition to. And then you can sign on as an individual too, and I think those links are on our PNHP website. So that's the thing we're pushing for now, is to get as many organizations as possible to sign on the letter that's going to Becerra. I think there's 90 organizations around the country that have signed on, that I heard from the national office today, and the hope is to get 200 organizations by the end of the month when the letter will be sent. And Claire made reference to the speakers training that was going to happen today, but 2 days ago, the opposition put out a letter to Becerra signed by tons of DCE organizations and other organizations asking him to keep it. And, they recommended some improvements to it, but definitely keep it. And I can could share the screen with that letter, but it's probably not worthwhile at this point. You can take a look at it and see what those organizations are that signed on to that letter. But so anyway, the national office had to scramble to get a response to that letter, which was sent out, I think today, maybe yesterday, the response to that pro DCE letter to Becerra. So I've got, I think those are on our websites, or I got links to them.
Okay, Hal, you have your hand up.
Yeah, thank you. I thought that was an excellent video from Claire. I was very impressed. I'm wondering, how active is Bernie Sanders in opposing this, and also our delegation from Washington State, including Dr. Kim Schreier and Patty Murray and Maria Cantwell? Are they actively opposing this, or do they have a position on this in writing?
What I know is that, and this is not as of today, but I looked at the letter when it first went out, and the only person from Washington State who signed on was Pramila Jayapal, who was the chief author of it. So even Adam Smith, my congressman who supports Medicare for All, has not signed on. And healthcare is not his primary concern. And I think I've sent him an email, but I haven't heard anything back. I've got to do something more aggressive to contact him.
How about Dr. Kim Schreier?
She wasn't on there.
Do we know?
I saw, I think, an updated list, and Adam Smith was on there.
Oh, good.
Hey. Definitely Schreier once, but also, what's her name? The new one from Tacoma. Strickland signed on. But
oh, good.
And let's see.
Well, my knowledge is definitely behind the times. Go ahead, David.
And Eric Larson too.
So David, I couldn't hear you. Did you say that Schreier has definitely signed on?
No, definitely not.
She's not. But Strickland has.
Yes.
Thank you.
I don't think there's been any such letter in the Senate. This is basically the House. And I think Pramila was the main one that was behind getting that started. She's been working with PNHP and other organizations, Social Security Works and Public Citizen and ones like that to get this DCE stopped.
Yeah. Okay, Hugh.
So this may be a rhetorical question, but who was the genius who proposed that this is going to save the federal government money? I mean, is it by proposing an intermediary? I mean, what could be the result but to deny care to people and to further decrease payment to physicians? Because already, what's that? You can hear me? Already, the Medicare reimbursement to physicians and hospitals is, so low that it's incredible. So, like I say, it's a rhetorical question, but is this an equivalent to ACOs, accountable care organizations? Is that what they pitched this deal as?
Yes, there's DCEs are pitched as accountable care organizations.
Yeah.
And, there's a lot of controversy about accountable care organizations.
Oh, yeah, absolutely.
Because basically they do better when they restrict care.
Oh, sure. Yeah. That's how they make their money.
And there's a lot of claims out there about how ACOs save the government money, but then there's other people who say that's a lot of baloney. If you look at the studies, it might save them like 1% or something, but then if you add in all the extra costs that go along with an ACO, then most of them are losing money.
Right. Oh,
well, the bottom line was this was an attack on fee-for-service reimbursement, essentially.
Yeah.
And so, and when you look at the history, fee-for-service, there's really no studies out there that show the fee-for-service is responsible for the high costs of healthcare or inflation in healthcare. Really, and if you read Kip Sullivan, he says this all the time. They really have not really done good studies that show that fee-for-service is the problem. Just
the only thing we have are occasional news stories of doctors who are, or entities of one sort or another who have abused the system and overused technology or overused services, et cetera, to beef up their incomes by billing for more services. And such people exist. Remember good old Johnny Delashaw?
There are a few out there, but when you look at studies overall, they really have not shown that fee-for-service is the problem.
Exactly, but there's
always going to be outliers.
They're leaning on this.
The problem is the high cost of our medical care. It's not the overuse, because international studies show that we use less care than most other similar countries.
Right.
Mm-hmm. Yeah.
Well, the scam is going to be they're going to charge us thousands of dollars to save us pennies. Basically, I feel like that's the concise way of putting it.
Yep.
And don't let it be lost on us. Sorry, I'm dying to get this to piggyback this point. And hearing the training another time tonight from Clara, she said that this will be an attack on the solvency of Medicare.
Yeah.
Which there's going to be politicians. This to me seems like they're playing chess. They're going to let Wall Street do their thing, like eat from the public trough, bleed these people dry. And then when Medicare is completely dysfunctional, they're going to go, oh, see, Ronald Reagan's right. Government's part of the problem. Let's just junk the whole system and just, I think that absolutely that will happen, and I would expect in the midterms that politicians are already going to lie and say that, oh no, these DCs are saving us money. But I think like it's a 1-2 punch, let Wall Street eat from the public trough and then just destroy the solvency of Medicare.
Yeah, I don't want to cut off Kathleen because she's next, but yeah, there's also been studies that there's never been studies that show that Medicare Advantage has saved any money. It's actually cost Medicare even more than it does for traditional Medicare. One of the reasons they rolled out Medicare Advantage was to, quote, save money. And
right. That's always the excuse. But
and also there's also to increase the quality of care, which it definitely has not. It has made it worse actually for a lot of people that are getting Medicare Advantage. So Congress is just not aware that all this is happening. They just don't know. And one more thing, sorry, Kathleen. The Center for Medicare and Medicaid Innovation was created under Obamacare. And in it, it specifically says that Congress has no say over what happens under that organization. And so you wonder, did the people that passed Obamacare, did they really read the 2,000 pages that it was written on? Did they really look into that and see what was really written? I don't think so. I think they were just so elated that Obama was addressing a healthcare problem, but that's the way he did it, was to further privatize the system.
Well, I don't think it was even intentional on the part of Obama. I think remember, Liz Fowler was instrumental in writing the program with Baucus from Montana.
Yep.
And Obama is sort of counting on these people to do the right thing. Well, not exactly.
Well, Liz Fowler was a lobbyist for the insurance industry at that point.
Right.
So we're like, so they slipped that in there because Max Baucus, she was a minion for Max Baucus. And back then, she was instrumental in fighting progressives to make sure public options were not put in.
Right.
And so lo and behold, travel through time, because that was like 2011 or 2010. And they slipped in that innovation there. And sometimes innovation is not a dirty word, but when it comes to public policy, it's expect bad things. So when we have something created called the Center for Medicare and Medicaid Innovation, that is like that's like a dinner bell for Wall Street to say, hey, come eat from the trough, quote, innovate,
It's a red flag for us too.
Right. Okay, Kathleen.
Right. Well, and now Liz Fowler's back. She's returned.
Yeah.
Yep.
Okay, Kathleen.
So I would like to say that I think that we need a template letter for individuals to sign on to what they want. And it could be people who are covered under Med Advantage programs or covered under Medicare, and allow them we should just disperse it really widely so that maybe even publish a copy of it in the Times, and allow people to sign it and send it to their whomever. I recommend that we send it to Becerra and that we just deluge his office with thousands of letters saying that we do not personally want to have anybody touch our Medicare or remove us from the basic program, putting us into either a Med Advantage or a DCE entity, a direct contracted entity, and that we withdraw permission for him to do that or to allow anybody else to do it, and that we send a copy to our representatives and senators, and that requiring or requesting that there be some legislation passed to allow congressional oversight of that organization if they continue this program.
Well, we need to do better in congressional oversight. I don't have much faith in them these days either.
Well, just put them on the spot. Yeah. It could be something different, but we need government to be responsive to us. Yeah. I mean, this is our money that we put in, and our employers also, I think employers need to stand up and say something. They have contributed 1/2 of what we put in, and those dollars came from their coffers to make this program to make this Medicare be solvent. and to provide for their employees who retired. And so honestly, I think they should be in this fight too. Maybe there's a way we can get them in. I don't know. Somebody else may have to think that through.
Okay, Margaret.
Hey guys, I was on another Zoom call with the lawmakers staff, and I take a lot of notes, but they get jumbled. I think it was with Murray's staff. It makes sense, but I know maybe Sherry Lambert knows Elizabeth Marshall from Lummi Island, and she asked the staff person, "What are you going to do about DCEs?" And the staff person, clear as a bell, said, "Oh, it's up to the constituents to organize that." And then what I thought of is somebody in Whatcom County who's under the active DCE steamroller is allowed to request a congressional inquiry. They say, "This is happening to me. I want you to examine it, oversight it, give me some answers." And they have to answer in 48 hours. They have to give you an answer when you submit a congressional inquiry, because I did it once, and I got an answer in 48 hours. So the lawmaker goes to the agency. You say, "I'm having a problem with this agency," and they have to go to the agency and look up your name and find out who you are and what's happening. So just for Whatcom County people,
we have contacted Rick Larson, and he had never heard of these things. So we've educated
go straight to Murray. Go to Murray and Cantwell.
And to Murray and Cantwell. And I've written to them, and a lot of people on my committee have written to them too. And pardon?
But just requesting an inquiry, say, yeah, you know what I mean, right?
Yeah, yeah. Well, I've sent Murray and Cantwell, and I get the feeling this is such a new thing for them all that they're still processing it. But I didn't like that letter that just went to in support of them. That's gonna sway some of them. But we just have to keep hounding them and talking to them and educating them about it.
I was on a conference call with Murray's staff yesterday with 6 other people from Healthcare as a Human Right Washington.
Uh-huh.
And, I laid out the DCE plans, and the guy who was the chief health staff for Murray said he knew about it, and they were looking into it. Murray, the closest she's come to anything from our point of view, Medicare for All, is she's the chair of one of the congressional
health committee. Yeah.
She said that she's in favor of traditional medicine, Medicare expanding and getting dental, vision, and hearing like Medicare Advantage does. So she's in favor of that, but she wouldn't go so far as to say she's in favor of Medicare for all.
No.
Did she understand the threat of DCEs?
I don't know.
Was she there, David?
No,
it was just her legislative aides.
Three aides, including her main health policy aide.
3 times I've been to Washington, all I can say is no one sees the Great Oz.
Well, usually they're pretty liberal, but I think they'll sign on to it. We're just hounding them. We really are. So Elizabeth Marshall's doing a good job too of advertising this. Great letters to the editor. We've had editors and we've added editorials. So we're getting the word out up here.
Fantastic. You're doing better than Seattle. Hasn't been anything, not a peep in the Seattle Times.
Wow.
Well, maybe that's our fault.
Yeah.
Well, maybe.
Hal?
Okay, Hal.
I would think the American Medical Association and the American Hospital Association would strongly oppose this for the reasons that Hugh mentioned a few minutes ago. Do we know if they have a position on this at this point?
I saw a list of the people who signed on this letter to Becerra to keep the DCEs, and I didn't see the AMA on there, which kind of surprised me. I'll fiddle around on my computer and bring that up. you know.
So also the American Hospital Association, I think of those two, I mean, they both have some clout in DC. The American Hospital Association probably has more clout and are very adversely affected by this. So if you could look into both of those, that would be great.
I'm not so sure they're adversely affected.
Yeah.
I think they're investing in doing this, and it's a way to increase income and decrease output.
So Sherry, do you think that's true for both the AMA and the AHA, or just the AHA?
I have no idea about that, but I can tell you one thing from my own private experience. I get my medical care from a doctor at the polyclinic. The polyclinic, although if you go to their website, it boasts about being owned and run by physicians, but it has been bought by Optum, which is an arm of United Healthcare.
United Healthcare, right?
Yeah. And I recently received a letter saying that I have been included in an accountable care organization. Nothing, no permission was asked or anything, just, and it emphasized that I still have full choice of physicians. I can go to anybody I want and all that. But I didn't like either thing about it. Either that something, a big practice like the polyclinic being owned by an insurance company, or having it just sort of put me in an accountable care organization. So it's again flying below the radar. The only reason I noticed it is I didn't throw the letter in the garbage can. I read it. I think it is now in the garbage can.
So one other point, Pramila Jayapal or any of these people could make a request to the GAO to have them analyze the question of whether DCEs are actually going to save money or not. So the GAO used to be called the General Accounting Office, and now it's called the Government Accountability Office. And they work for every member of Congress. It doesn't take a vote. All it takes is a request from any individual member of Congress to the GAO to do an analysis. And they have economists and others who can crunch the numbers and actually do this analysis and issue a full report. So I'm wondering if maybe we could encourage Pramila Jayapal or someone to actually just send in that request to the GAO.
So the thing that's scrolling by here, this is the list of people who signed the pro DCE thing.
Yeah. And I'm wondering, is this Providence Medical Group, Providence Health and Services, Providence? Is that our Providence?
Yes.
Yes, that is.
So we know where they stand.
Well, and you scrolled past it, but Optum was on there.
Yeah, I think that's a DCE in itself. Well, I think a lot of those, or many of them, are, if not most, were DCEs that are already existing.
So David, is there some way of seeing if Pramila could send a request to the General Accounting Office?
We can request in our own letters, Hal. Write our own letters and request it.
No, but I'm thinking, I mean, if we probably have some direct connections to Pramila. So, and all it takes is one person. It doesn't have, there doesn't need to be a vote on the floor of the House or the Senate. It's just one member.
Well, does the GAO have any? Yeah, does the GAO have any power to overturn what CMMI wants to do?
No, but they can give the fuel.
Yeah, it wouldn't be power to change things directly, but indirectly by providing. So the GAO reports are typically very, very detailed and would give members of Congress a sound basis for opposing this.
Yeah.
Yeah, we could put together a letter to Pramila.
How long would that take?
Can I just interrupt for 1 second? Hal, you know that Seattle Indivisible meets with her every week, right?
Good.
Well, this would be a good thing to bring up if you meet with her every week, is to ask the GAO to do a study of what this is.
Mary, how you guys, can we meet afterwards really quickly, briefly? I don't mind asking to do that, but I just need guidance.
Sure.
Okay. Okay, Merle, you're next.
Carol, you got to unmute.
You'll need to unmute. There
I don't
you
know if
go.
I'm missing something. You can hear me now, right?
Yes.
I don't know if I'm missing something, but is the only way we can get this sort of intermediary that's causing us the problem to be rolled back by Congress, or is that what we're obviously trying to do, is to get Congress to get rid of that
Yes.
intermediary? And then also, you know, San Francisco's got a waiver so that they would get their Medicare flowing into them because they're a healthcare for all entity. Would that be a palliative to this? Would be creating your own state healthcare system way to not have to convince everybody in Congress that this is not indeed a way to save costs and profit by it.
Thank you.
Anyway, that's a question I have.
Well, answer to your first part was, does Congress have the ability to change the intermediary organization, the CMMI? They do. They'd have to reopen the Affordable Care Act and actually strike that from the Affordable Care Act.
Mm-hmm.
Well, I say good luck with that.
That's probably a harder way to go than to pile on to Becerra.
Correct. I agree.
Right. Okay, Andy, you're next.
So actually, I'll tag on to that. I think that in answer to a theme that people keep asking here is any politician, whether they're in the Senate or they're in the Congress, if they take money from the health insurance industry, they are going to be huge on. They're not going to be cooperative on this as far as stopping the DCs, because they're going to have that conflict of interest, and not to mention they're going to make it an ideological argument. And I'm very concerned, if you observe from the last decade, the new tactic from the insurance industry or whatever the establishment, they want to delay things. And I think in this case, I think it's great if we can get that an economic study going that was brought up by Hal, but I just don't want to see, I would hope that we keep fighting the initial battlefield on the front lines and just get this nipped in the bud ASAP, because I just think they're going to be using every tactic to delay stopping this. They really want to get it done. You know, I think the last meeting, I don't know who brought it up, but I think David even mentioned maybe 2025 is the new, they want to get it completely privatized from 2030 to 2025. But they're going to make it ideological as well. They're going to say, oh, well, this is a conversation about private versus public. My guest tonight, Eric was talking about this with his wife during the presentation. And that was, I think it'd be interesting for him to ask his question, because they will absolutely try to make this, the opponents of what we're talking about will make this an ideological conversation. I think we need to initially not make it political, because we should just make it as common sense. Is look at how efficient Medicare is. But I just expect that. I expect in this fight, they're going to do a lot of things to delay taking action to stop this. And I thought the last time in January, there was discussion about having Biden just kill this with executive order. Because my understanding is he has the power to kill DCs with the executive order. And I do think that the kid gloves have to come off. We really have to just really publicly pressure Patty Murray and the other ones. Because my understanding of our Washington senators is they're a bit friendly with the insurance industry. So I don't know if they're going to they'll go along if people lean on them maybe, but I don't know. I mean, people can chime in, but I think my thing I keep saying is I just think we have to get the message out there as loud as clear. So enough people are talking about it, because it's very interesting how quiet they've been trying to do this. I think they know that they're in the wrong. they know we would win this argument, but the argument's not even being had right now in the public spheres. You know, this NPR is not talking about it. You know, it's not in, and the people that mentioned, well, what we can do in Seattle. Well, I don't know if the Seattle Times, they're a bit conservative, but the Stranger might be a good way to go. I bet they would tackle it. But
yeah.
Anyway.
Yeah.
I would be happy to write that for the Stranger, or to get someone to get going on that, you know.
I think,
but
well, that's a good,
anyway,
that's a good thought,
yeah.
Andy. Go ahead, write something and run it past the rest of us for just editing and commenting, to make it not too, because it not too wild, but okay. So go ahead. Okay. All right. Sherry, you're next.
Great. But I think that's what we're facing.
Okay. Andy, send it to all of us so we can use it as a template to send to our representatives too. But I was going to say in Whatcom County, our only hospital is Peace Health Hospital, which is a Catholic hospital. And they have taken over more than 50% of the physicians' practices, cardiology, orthopedics, all the critical ones for older people, for everybody. But, and they are now formed, their physicians are put into a DCE, Cascadia Care, Community Care Alliance, CCCA. So all the physicians are in that, and all the patients that were on traditional Medicare have been put into a DCE. And the community is pretty upset about this.
Wow.
And if it was such a good program, why are they trying to slide it in? If it was a good program, why aren't they advertising it? Then that list that signed on to that, the letter to Becerra, most of those are for-profit equity firms, and like the kidney dialysis centers now, they don't want people to get a kidney donated to them because they want to keep people on dialysis because they're making so much money. Check out I can't remember the names of the two big ones up here, but they control all the kidney dialysis, and it's very scary. They're just taking profits left hand over fist.
There was a PNHP study, I think, comparing for-profit and non-profit dialysis centers. And they found that you were going to die quicker in a profit one, and you were much less likely to get on the kidney list.
Yeah, that's right. That's what I was just going to, that's all I wanted to add right now.
I think it's DaVita dialysis.
DaVita, that's it, yeah. Oh, they're owning a lot of the practices. Yeah.
Wow.
Yeah. I was an x-ray tech, and back then care was good, but then HMOs came in, and now it's just kept getting worse and worse and worse.
Okay, Hal, your hand is up again.
Yeah, I agree with everything that Andy said. And in particular, I think Andy is correct that Biden could handle this through an executive order. And so I'm wondering I'm hoping that Pramila Jayapal is aware of that. And I think the pressure should not be just on Becerra, but really should be on Biden. In fact, it might be more important to communicate these concerns with Biden than with Becerra. So Becerra is he's at the cabinet level. He's at the highest level. He reports directly to Biden. So if Biden could raise this issue with Becerra, it could be pretty powerful.
I think at one point Becerra said he was in favor of Medicare for all too.
That was back when he was in California.
Then Biden has said he'll veto any health care for all program that comes forward.
No. Okay.
I want to ask, what do you think about, I think my first sentence in the letter I'm thinking of writing is going to be that I do not give them permission to move me from traditional Medicare. And I'm wondering, is that not a place of power?
Well, I think Sherry mentioned that were you placed into the DCE because your provider was and you're out in the rural area? Because
people that everybody was that had traditional Medicare was put into it.
And you can get out of it, but then you lose your provider because your provider has to have.
You have to, yeah.
So you're not going to do that if you have to go 50 miles to see somebody else.
That's right. Or, you like your provider, you have a relationship with your provider, you don't want to quit. You want to change.
I'm intrigued by the fact that the letter that I got so far says I still have the ability to go to anybody. That it's just an accountable care thing where they're going to be looking at overall costs, but not restricting me in my choices.
But you're not in a DCE.
No, it's not a DCE. It's an ACO that's within the polyclinic, which is owned by Optum.
Okay, well.
So isn't that a DCE? Isn't Optum a DCE?
Well, no, they own the physician's practice, but that doesn't make them a DCE.
It probably is because why that's the middleman right there. Why do they own a physician's practice? Because they're an equity firm.
Because they can.
Yeah, and they can take 40% off for their profit.
And as I mentioned in the chat, trying to find a primary care provider, even in Seattle, that I've helped my friends who have moved to the area, is a thrash. It is very difficult. And the only people that are taking new patients are people that are fresh out of training or mid-level, associate providers. It is amazing the paucity and the shortage of primary care providers anymore. It's, they say, go get another doctor. Well, yeah, give me a break. Talk is so cheap.
And mental health providers, that's
non-existent really unless you show them cash up front. You're not going to see a mental health provider unless you stick a gun in a policeman's face in broad daylight and you get thrown into Harborview.
No, you get thrown into jail. Maybe you
for
Harborview.
Hey, a quick question. I don't know if there's any more specifics about what's happening in Washington itself. I don't know if I heard this or saw it in the presentation, but something like 5 or 6 DCs are operating in Washington state. I had a chance to meet with one of Schreier's legislative aides a month ago, and her big question, hadn't heard of the DCEs, but the big question at that point was, how is this affecting people in Washington state? And I didn't have a great answer for her. Do we know which organizations or how many numbers of citizens or any other specifics?
Well, I can bring up a list of the 5 that are operating in Washington state. There was a great letter to the editor and that I saw. Healthcare for All Washington passed it around by someone who found that they were in a DCE and got very pissed about it and wrote a letter to the editor that got published, and that one should be widely disseminated.
Was that in the Times, David?
No, it was somewhere in the
it was up here.
Olympic Peninsula, I think.
Oh, and we had it over in Lummi Island. They had it, and our local Whatcom County papers had it. Good articles. But isn't, in answer to your question, isn't it? It's going to. How many people will this affect? Is what they wanted to know. When it's going to affect everybody that's on just straight Medicare, and 40% of the people are on Advantage plans. They're already getting screwed, but that's different. But the other 60% are going to be put into this, so it's going to affect more than half the Medicare population. And younger people, as they come into this, they need to be aware, because if this happens, they won't have Medicare. It won't be available. Anyway, I'll quit ranting.
Okay, so
that's my fear.
Hands in the air. Kathleen Randall, do you still have your...
I want to ask if people who are in MedAdvantage plans are also being converted into DCEs. In other words,
yeah, Medicare Advantage plans are part of the DCE system. They can, you know, buy up or become a DCE.
oh my goodness.
So are you looking at this? These are the ones in Washington State. Can you see this list?
No.
Not right now.
No,
It should be on a screen share.
It's not shared.
it's not sharing so far.
Okay, let me try it again. But this is a list of the DCEs in Washington State. I'll have to come back. I'll try to get it up again. Go ahead.
Okay. Next up, so is that the end of your question?
Yes, thank you. Thank you.
Okay. And Andy, you have your hand up again, or is it still left up from before?
No. Well, people may ask questions, and then I'm like, oh, I know the answer to that one, and I'm like, but I wanted to comment. I mean, well, people are asking about the reliability of the AMA. I mean, traditionally, they were one of the biggest opponents to a single payer type thing. But I think like, and some other comments people have made, it alludes to, would the medical industrial complex benefit from DCEs, or would it be a hindrance to their profits? I feel like that would take some digging to get a solid answer to that question. But I do think one thing to focus on winning people over is that DCEs will definitely add to a new layer of bureaucracy between you and your doctor. And that's a winning point. That's a winning point that even conservatives, you know, that was their big thing, you know, like who gets between you and your doctor, you know? So I think that when we're trying to fight this fight, I think we should focus on that. Like, who wants one more level of bureaucracy, especially when it's a level of bureaucracy that will profit off of getting in the way of you and your doctor? You know, what kind of tests are they going to deny to say, oh yeah, you don't really need that test? You know, we know that it's going to go down that avenue. So that's that in a nutshell. Is I think we should, I mean, pardon?
There's Peace Health right in the middle of it, our only hospital.
Yeah.
But I mean, I know for me, like, that's why I've done different healthcare systems. You know, I've done the VA, I've utilized America's private healthcare system. I watched my wife struggle in it, and it's just, no one likes dealing with like an auto, you know, press 2 to talk to the, you know, like it, no, who wants to spend another 30 minutes on the phone just to deal with, like, should your doctor prescribe tests? Should that be something you get to do? No, I got to like check in with sorry, my kids now are running around by my feet. So, but anyway, you see what I'm saying? Bureaucracy bad. And this is going to create more bureaucracy.
Oh,
and I think that's a winning battle. That's something that we can win on for the voters, at least, you know?
Okay.
So you saw that list of 4 that was in April, but Humana is now operating in Washington State as for DCE. So there's 5 of them now.
Oh. Okay, Merle, you have your hand up.
Yeah, back at it. You know, I'm wondering if this might be a plan to try to do what I think one PNHP spokesperson one time said, that the reason why we want a national plan is so that other states wouldn't be hurt. But I'm afraid, you know, here in Washington State, of course, that we're a richer state. We might be able to pass something like this, and that would be something that would cut off these other states from having any kind of a decent health plan. But these other states, which I'm saying would be ones that certainly are poor, would buy into the line that this is a cost-saving measure, that this is something that profits people, but it's billionaires, and so it's okay. But my thinking is should PNHP maybe address a state program, you know, 1-by-1 state program, or 1-by-1 city healthcare program, and maybe not, maybe change their name to to Physicians for a National Domino Effect program.
Well, Well, I don't think PNHP is going to change its name, but it has always been reasonably supportive of various state efforts that are gang together in an sort of an umbrella group called One Payer States, who meet and talk to one another, especially now that everybody knows how to do Zoom. So it definitely a two-pronged approach. Yes, we need a national system that makes sense. Maybe we'll get there directly, or maybe we'll do it by getting some state to go first and show everybody how it can work. Who knows? Right. Okay. Hal, you have your hand up again?
Yeah, I think Scott made a really important point. I think he said that he met with congressional staff and they asked some questions that were hard to answer. And I think a lot of members of Congress respond most to things they hear from their own constituents. They respond to personal stories. And I'm wondering if Citizens Action, Washington Citizen Action Network, Washington Can, might be one way of gathering testimonials from people here in Washington state who have had the experience of being converted to DCE and have had a bad experience. Because that's what Patty Murray and Dr. Kim Schreier and others really need to hear. They need to hear from their own constituents about the bad experiences. So what's the best way to gather those testimonials?
Well, I think there's going to be an effort to put together a coalition, anti-DCE coalition in our area here. PSARA, Puget Sound Advocates for Retirement Action, is interested in this and is talking about maybe we should be doing direct actions outside of the, DCE offices. So I think people on this group here who belong to organizations should let us know, and we'll be putting some ways out there that you can join the coalition, because I'm sure, Washington Can, as I mentioned, was the first one on it, and they have tremendous reach across the state, 40,000 members, and they're good at gathering these stories. So I'm sure they would be an active participant in an anti-DC coalition effort. So
do we know whether any of these organizations are actually soliciting testimonials?
No, I don't. I think it's been under the radar for a year and a half. Not that many people.
I think it's
so far.
These things have been in existence less than a year, so it's going to be hard for there to be much in the way of bad experiences. It doesn't hit people until they need something and are denied it.
Right.
Well, fortunately, it only takes one bad experience to really, hit the headlines of the newspapers and get people's attention. So I think we should, if there is anybody who's had a bad experience, we should try to find those people.
Right. And that brings me back to remembering what happened to good old Johnny Delishaw, who was coasting along, raking in the money, as was the hospital, the Swedish hospital that was backing him up. They liked all that money coming in until a patient died. And that what's worse, that patient happened to have a parent or a spouse, I've forgotten which, who was a physician and who saw the bad care happening and became sort of a whistleblower of the whole thing. And then that brought the Seattle Times in, and and it exploded.
Right. That's why he's in California.
Yeah.
Is he in California now?
Yeah. He's down in California.
Surgical nurses too.
Pardon me?
Surgical nurses
right,
also blew the whistle on him.
Yeah.
He lost his privileges in Washington State. And,
He did. He
got a back door to Paul Krugman. This would be a great Paul Krugman article.
Yeah. I was thinking about the health editor at Seattle Times. Does anybody know who that is? That would be a person that we could maybe talk to, see if they would do an article on it.
Yeah, Times is going. They put up money, or give people the rich to put up money for their different managers of the paper. Like they're actually kind of doling out who has editorial control over different issues like that. So I'd watch out for trying to steer anything through a healthcare editor, if you want to call him, or somebody in charge of that, because they're getting a donation from probably somebody in the field that probably wants DCE.
That's for sure, for the Times. And
well, has anyone written an op-ed yet, or have we seen one in the Seattle Times?
No.
On DCEs?
No.
I think that would be a great place for Andy's letter to go if he ever drafts one, and we could all check it over.
Andy, you've got your work cut out for you.
All right, but just remember, the empire will strike.
You're breaking up, Andy.
You're breaking up, Andy.
I mean, you guys, can you hear me?
Yeah.
Can you hear me?
Yeah, now.
Can you guys hear me?
Yep.
Oh, I just said if that'll be shots fired if we put it in the Seattle Times. That the empire will strike back. So get ready for when they. But we can just make them look like fools, because independent of ever even doing a study, in a way, I'd say we don't need to do an economic study, because we can say right now it is mathematically impossible for DCs to be, when Medicare already has an overhead of like 2, 3, 5%. There is no way that you bring in a Wall Street venture capitalist type. I don't care if he went to McKinsey and what he studied on innovation. It is mathematically impossible for them to save us money. So, I mean, we kill the issue right there. We don't even have to do a study. I just want to make that point.
Right.
And honestly,
upcoding is against the federal law. Did you know that? They sued.
It should be.
It is.
The University of Washington was fined millions of dollars for upcoding when they shouldn't have been doing that. So let me tell you, it will come back, and it can come back. So upcoding that's the part that is illegal.
But they get around all the time.
I mean, this is where the scam is. But also, I think if we want to explain this in like layman's terms, because I don't know if Eric's still here, but his wife was listening, and to hear if like our message is like getting, but I feel like in layman's terms, we're essentially talking about when these people are going to step in. It'd be like if you go to the mechanic and the mechanic's like, oh yeah, I recommend you do this transmission fluid change. And you're like, well, I just came in to get oil. I don't want to pay another $100. Well, when it comes to your body, if your doctor says you need X, Y, and Z, you don't really want a guy with an MBA to step in and be like, well, actually, you don't need that. Or look how much money I'm saving by you not getting this MRI, I mean, that sometimes some things can be commodified, but I think we have seen in America the commodification of our healthcare choices. It just doesn't work, and this will just put that on steroids.
Right.
I really want to make sure we emphasize that.
Well, I think an op-ed doesn't have to have a total economic analysis of what's going to happen. We can the PNHP letter that they wrote, their template for an op-ed, did not have all that information in there. So I think that's something we could possibly put together and submit to the Seattle Times. Maybe they wouldn't print it. They probably wouldn't, but it's still something we should probably do.
It's got to be under so many words, doesn't it? Under,
correct.
What, 1,000 words or something?
I'm not sure what it is, but there is a limit on the words.
Stranger might be better.
What might be better?
The Stranger.
Oh.
Yeah, I think the Stranger would. I don't know. I don't have any context of the Stranger. It's more of their flavor. And again, I mean, I think we are still, unfortunately, in the beginning stages of just getting the word out. There's just not enough people that know about it. Really, I think
you can submit it to both. I mean, you write an op-ed and just
absolutely
throw it out there.
Well, the Stranger will probably want it to be a little more entertaining or moderately funny, which is not hard to do. Whereas the Seattle Times, we have to, and again, we can totally win on the business angle. But Seattle Times, we would want to do the what they call the conservative argument for single payer type thing, you know, like why it makes good business sense to not go with DCEs. Because what the beauty of Medicare is that it is universal. So even rich people, it doesn't matter your economic status. And yes, there are some people that have catalytic, you know, they have like just not a care in the world. And so maybe they wouldn't care. But overall, I know, I just think doesn't matter your economic status, I feel, when it comes to people that support Medicare, because it's universal. So I don't know. I mean, but you guys can chime in. I mean, you know more people in that demographic than I would, but am I right?
I'm not so sure. I think that I agree with that. I think that anybody who is having their personal business being moved around without their consent,
Right,
and without their permission and without their knowledge, and having people interfere. Upcoding is really something, because you can't get insurance if they upcode you from having a cough to COPD. Then you're in trouble, because you can't get coverage for some kinds of things, and getting life insurance. And I mean, that's really serious. That's serious stuff.
Well, and if you simplified the message into those 3 points, this doesn't make economic sense based on the percentage of overhead. It usurps people's individual choice.
Yes.
right.
And thirdly, it's illegal. I mean, those 3 simple points, I think, would be the foundation of a good op-ed. And I don't know, you know, it's not the best in the world. It's not but the Seattle Times plays relatively fair, I think, in journalism. I mean, it's an establishment, but it's also a local family-owned corporate business. Mm-hmm. It's not a corporation owned by a conglomerate. And my kids went to school with their managing editor, and I know her, Lynn Jacobson.
Wait, we have an in. All right.
So,
yay.
Come on, Andy, get that letter written.
Yeah, and
okay.
She's a good egg. She's not an idiot.
Okay. Well, maybe Andy will write the letter, and Hugh, you'll shop it.
And I'll call Lynn. I mean, here's a woman, you know, she was one of the managing editors at the paper. Her husband was an architect, but still they sent their kids to public school in central Seattle, you know, so they're progressive people.
Yeah.
Mm-hmm. Okay.
I think the trick will be to keep it apolitical, because at the end of the day, I think, while yes, inherently it does become political, I think the way we win is because it is, it affects everybody. You know, I know conservatives and Republicans.
Public outrage. Yeah.
Yeah.
I think it's not political at all. I think it's totally nonpartisan. It has to do with people's issues about healthcare, their choice.
Right.
Fairness, rightness.
Keep it there. And freedom of choice. Yes.
Right. Exactly.
That's something everybody can do. I'm just saying that
across all divides.
You go politically, you alienate a couple people. That's all I'm saying. You know.
So maybe I need to get in some giant truck and drive out in front.
Okay, we gotta go through the motions here of re-electing our board once a year. So
right.
Do that.
Right. So
we have a new board candidate in Andy Wellens, who's you've seen here tonight. So I think we had 2 more people with their hands raised. So why don't we go through those, and then
actually just one left, which is Sherry. Go ahead.
Maybe I had my hand up. And I just wanted to say, if Andy writes a good letter, then 10 people can send it. You know, he'll write it, and everybody
just vary it a little bit.
Get 10 left, and that improves the chances of them publishing it. But I also want to thank Andy for posting that article about Kucinich on the plane with Obama. He was in an interview. I think he's running for the governor of Ohio. And he said he got on the plane with Obama, and Obama wouldn't budge. That's why he got off the plane and voted the ACA. So thank you, Andy, for that. That's all I had.
Okay. Sherry, go ahead.
I'll post it in the comments.
Going to mention that those home visits that the advantage, I call them disadvantage plans, are offering, they're also upcoding. I think they are using those as a reason to get into your house, and you talk to older people and they like to talk about their ailments, so they'll just tack on a lot more codes. So I'm really, this is not a partisan issue. Republicans are getting hit just as hard as Democrats, and we need to reach across the aisle. And I think healthcare is the big equalizer. We all need it at some point in our lives. So,
thank you, Sherry.
And I talked to my neighbor who's on the opposite side of the fence with me, but he said his mother had just passed away and he could not handle all the medical bills. He just went crazy. He said to his sister, I'll do everything else if you just handle all these bills and all this stuff that comes through. And so we had a really good conversation about how we need it, how simple it would be if we had a single payer system. And he totally agreed with that. So I really felt like, you know, if you could just reach a few people that don't agree with you over too many things, it would be beneficial. Right. Because we're talking to the choir all the time. We all know what we need and why we need it. And I think we just need to get out and reach out to the other side more.
Right. And this is good common ground. And this is not only good for this issue, but it's also good to get some common ground to kind of settle all this extremism.
Right.
Yeah.
Right. I think what Sherry just said is a good ending point, which is essentially healthcare, everybody needs it. And you don't know when or how much or how or exactly why, but everybody needs it sooner or later. And so things that make it more difficult or make it more expensive because people are profiting from it hurt us all. And that is a good take-home message, I think, for tonight, that DCEs are another way to siphon off dollars that ultimately come out of our pockets and send them off to investors of some sort over our healthcare.
Corporations don't need health care. They use it as a bribe to get their employers not to leave their companies, their employees to not leave their companies.
Yeah, right.
Okay.
So we need to, so how do we do this? I think what we have done, this is the annual time that we re-elect the board of Physicians for a National Health Program. And everybody has agreed to hang on for another year in our current positions. Do we want to list everybody or just leave it at that? And
I can read the names.
Okay,
that's a good idea.
Okay.
All right,
good idea.
So we got, these are current board members who agreed to re-up for a year. Sherry Weinberg, Dana Iorio, myself, David McClanahan, Betty Capehart, Hugh Foy, Kathleen Myers, Kathleen Randalls, Seth Armstrong, and George Martin. So then we have the new candidate, as I mentioned, Andy Wellens, who's on the call tonight, who's been interacting with our board for the last couple of months. And, you know, we agree he's a very passionate guy who's got a strong grasp of healthcare policy, and he's enthusiastic, and he reduces the average age of the board by about 10 years. And he's agreed to, you know, be elected to the board and be our communications chair. And he's had a lot of experience with this in the past. So the other part, and also it's possible to nominate somebody during this meeting tonight.
Yes.
So
is there anybody, are there any nominations from the floor, so to speak? Nominations off the Zoom? I don't hear any, but I would also encourage that if there are any of you out there who would consider being part of the board, let us know, and we can give you a chance to participate in board meetings and the like, and see if it's something that fits, which is how we have recruited Andy. So,
question, David, was Betty Capehart on your list?
Yes.
Yes.
Okay. Sorry, I didn't hear it.
Yeah. Okay. So I will entertain a motion to vote in the board members as listed.
And I'll second it.
And Andy.
Yeah, and including Andy.
And I'll second it.
Okay. All those in favor, say aye.
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 Okay. All of those opposed, say nay.
The ayes have it.
The ayes have it.
And we don't have any Zoom bombers.
No.
No, we don't. We don't. Okay, so we've taken care of the business aspect of things. So I think we're about done. Does anybody have anything else for the good of the order? Except
Well,
Andy, we're waiting. We'll expect something from you. Just put something down and send it off, and we'll pick at it, add to it or whatever.
Okay, great.
Perfect.
As I kind of said in the email this week, I think we will get a lot of. I've been putting a lot of by the way, the reason I'm like moving around all the time is because I'm still in dad mode. Like our kids are getting bathed and all that. So occasionally I disappear. If anybody's getting vertigo, I'm just like, all right, I'm gonna. But
I think we've all been there.
Yeah, like my wife tolerates this because I'm like, hey, it affects us too. Someday we want to use Medicare. We don't want it to be gone, and she's like, great. She believes in it. So if ever I'm just like moving around, that's what's going on. I'm like, but I'm trying to, I'll just be in touch about the letter.
Yes.
In fact, how about this? Because I'm trying to actively get our other social media stuff up and running and going. If people have immediate thoughts and talking points that you want to hit, because as good of a writer as I am, I got that MFA in it from USC. I'm a great editor as well. So, I mean, it will probably happen even faster if people want to slip me any of their talking points and I can like really jazz it up. And, we always want to consider your audience. So, I mean, the letter for the stranger probably be different from Seattle Times, but that's not a bad thing. That's a good thing. I mean, the stranger will probably preaching to the choir on that one, but they don't know, I'm sure, so Seattle Times, maybe we're trying to convert some people anyway, but yeah, send me your input about the letter. Everybody who's here who has input, send it to me and I will write a beautiful letter. And if we do know like the word count, that'll be very helpful. So that's my piece on that.
I would go on their Seattle Times website and see what they say about it. They may have something there.
I think it's about 700 or 800 max on the op-ed and 200 on the letter to the editor. But
thank you.
Need to go
that's right.
Something like that.
Yeah.
And this is one of those months where the third Wednesday has come before the third Sunday. So this coming Sunday is our board meeting. And no, Andy, you don't have to get it done by then. But if you do, that will be a great opportunity for us to talk about it.
Well, I will do my best. So
sounds fine.
Andy, you should put your email in the chat, Andy. Put your email in the chat.
Yeah. Okay, great. Yeah, because I think I've been getting lots of emails from the group, so I feel like that.
Well,
but
it was
I can put
the
it again.
people here who are at the meeting who may also have some.
Oh, okay, great.
Yeah.
Is my friend is Eric still here? I know he still had some input, but anyway.
Yep, Eric is still listed here.
Raise your hand, Eric. Throw in your 2 cents. Anyway.
No, I don't have any cents to give. I'm just hanging on to my money and just listening and taking it all in.
Okay.
Well, you had that great question from your wife, though, that or did I address it?
Well, I mean, it was just you know, my wife comes from a Republican family, and she just asked me the question, you know, what's a DCE? And I didn't really know what to tell her. You know, I just told her it's a type of company that plans to privatize Medicare. And then her first reaction, her first question to that was, well, maybe it's because they think that the government is not handling Medicare correctly. And so my point to you in the chat, Andy, was, you know, that could be something that a conservative-minded senior would say. You know, maybe the government's not handling it right, because a lot of conservatives are in that mindset, which is the government's the problem. Ronald Reagan said so, and I believe him. And so that was the issue.
Yeah, I think that's a good. I mean, I think it's good to kind of hear that outside perspective, because that's we want to reach everybody with this message, you know.
Right.
Yeah.
Okay,
Thanks,
everybody.
I gotta go.
About time to go. It's 2 minutes to 9, so we're not abusing anybody's time. Yes.
Sherry and Hal, if I could just keep you for 3 minutes, just to talk about Pramila. It's next Monday, I believe. It's every week.
Oh, okay. David, can you do that? Or can you just stay on also for a few minutes?
Yeah, sure, I can stay.
It won't take very long. Thank you.
Okay.
Bye-bye, everybody.
All right, everybody else, enjoy. Have a good
Great
time.
Good meeting.
Yeah.
Absolutely. Thank you.
I particularly enjoy participants from other parts of the state.
Yes.
That's really nice. Yeah.
Our mission.
Thank you, guys. Just wonderful, wonderful.
Okay, I'm glad you enjoyed it.